There are two COPD conditions. They are emphysema and chronic bronchitis. Acute bronchitis is obviously not COPD because that's acute. We get repeated bouts of acute bronchitis, but that won't leave any lasting damage to the lungs. Asthma used to be a COPD, but they have put asthma under allergic conditions now. However, you'll notice that when we discuss COPD, asthma is in the same chapter. Asthma, in fact, is treated with the same medications as COPD patients. You follow so far? Okay. So why is it called COPD? Because it's a slowly progressive respiratory disease involving airflow obstruction. So we'll discuss how this happens, how it involves chronic changes to the lungs. There are again two types. We have emphysema and chronic bronchitis. Most people with COPD have both. They both have emphysema and chronic bronchitis. I say most because the most common cause of COPD, namely emphysema and chronic bronchitis, is smoking. That is the top cause of the disease. However, there is a small population of patients with COPD with no smoking history. No first-hand, no second-hand, no third-hand smoke. However, they have a genetic condition, a genetic deficiency of a certain enzyme. We'll discuss that as well later. To examine how exactly it develops, let's look at each one. Let's start with chronic bronchitis. When we say chronic bronchitis, this is the upper airways. This will involve the, let's imagine your respiratory system. So we have the upper and lower respiratory tract. So chronic bronchitis involves the upper airway. So if this is your trachea, and this is your right and your left main stem bronchi, and these are your two lungs, right lung, left lung. Okay. So chronic bronchitis involves the larger airways. So it will involve this section here up to here. This is chronic bronchitis. When we say emphysema, it involves the lower airways, which is now the lung tissue. So this here is involved in emphysema. Now, how did that happen? If you read the entire pathophysiology, I'll summarize it. So this is how our body works. Is the air we're cleaning sterile? Where the air we're breathing, is it sterile?
No, it's not.
So therefore, that makes our respiratory system, is it sterile? No, our respiratory system therefore is dirty, right? Because we're not breathing sterile air. Now, because of this fact that we're breathing in dog poop, cat poop as we're walking around the neighborhood, how will our body rid of them? How do we rid ourselves of these pollutants, these irritants? Well, we have built-in structures. Number one is the mucus, right? So we have mucus production from our nose, actually, all the way down to the lung tissues. So we have mucus producing cells there that produce mucus, protects us from irritants. So whatever solid particulate matter we inhale, they stick to the mucus, and then we have what propels the mucus upward. What do we call those tiny finger-like projections? Cilia. Microscopic projections? Cilia. Okay. So we have cilia that propel mucus upward, and then we wake up in the morning, we have a very good right? And then we spit out the mucus, right? We also have our sneeze reflex, which protects us from the same irritants that also increases mucus production or stimulates mucus production, allowing us again to expectorate any particulate matter. Now, in most cases of COPD patients, what's their number one risk factor again? Smoking. Okay, either first-hand, second, or third-hand smoking. So that causes irritation, correct? So cigarette smoke or other pollutants irritate the airways, and then this again causes mucus secreting glands called the goblet cells to increase mucus production, and you know the rest. Now, in order to break down debris, in addition to mucus producing cells, the goblet cells, we also have something called protease. Protease is an enzyme that will help break down debris. Meaning, for instance, if you are a smoker, so every time you inhale cigarettes, so there will be irritants, right? You're inhaling irritants. You will produce protease. What will protease do? It will break down or destroy debris. So debris from the cigarette smoke, from whatever, the dog poop, cat poop, human poop that you inhale, it will be broken down by protease. Now, in the case of a smoker, since they do the irritation, the exposure to the pollutants constantly, what will happen to the number of protease, to the amount of protease that they are producing? Okay, let me repeat. Protease is an enzyme produced by the cells along your respiratory tract. The more irritants you inhale, let's say the more dog poop, the more smoke. Okay? So you're a smoker. You constantly smoke 1 pack a day. So what will happen to the amount of protease that your body is producing? You're smoking. What will happen to protease is an enzyme.
Yeah, so when we decrease our
the more you put lollipop into your mouth, what will happen to the amount of saliva? So if you eat 100 lollipops, will you run out of saliva?
no.
Okay, let's put this into perspective. Okay, so protease is an enzyme produced to destroy debris, foreign debris. So the more you smoke, the more pollutants you put into your body, into your respiratory tract. What happens to the amount of protease your body is producing? It increases. Now, at night, can a smoker smoke 24/7? No, they cannot smoke 24/7. However, because there's protease, which is now increased in amount, what will happen if the protease runs out of debris to break down? There's no more because you stopped smoking. You went to sleep. Okay, but you still have active cells producing protease. So what would protease do? It has to destroy something. Once it's produced, its job is to do what? To destroy something. That something is supposed to be cigarette smoke or whatever debris you're inhaling. Now you went to sleep, but protease is still there. What will protease do then? Will they just go away? No, they didn't get dressed up for nothing. They're already there. So what are they going to do? They have to destroy something. They will destroy your respiratory tract. So we're still in the bronchitis, chronic bronchitis part. We'll get to the emphysema later. So now, because you have so much of these protease now, what will protease do again? Destroy whatever they can find. In this particular instance, they will destroy your lung tissue, your large airways. So this will cause chronic inflammation as a result. causing large mucus production and inflammation in your airways. Now let's go to emphysema. Emphysema, on the other hand, is now the same problem. However, it's now involving the lower respiratory tract. So if this is what's happening in the bronchus, so this is called chronic bronchitis. Look at the lumen. This is supposed to be what your normal airway looks like. After COPD, after you develop chronic bronchitis, this is now what it looks like. Look at the thickness of the wall. How many times is it now bigger, thicker? It's now up to 4 times thicker, narrowing your airway. So can you still breathe in normally here?
No.
No more. So that's why it's called a COPD condition. Now let's go to emphysema. This is now involving the lower airways. This is now emphysema. Now, how did it get there? Your lungs are supposed to look like this. This is normal airways right here. They're supposed to be individual grapes. You have 100 million of them. So both left and right lungs together will have about 100 million alveoli. Now, they're supposed to be individual air sacs like this. Now, what happens in emphysema? Do they still look like individual air sacs?
No.
No, they become one big blob. Okay, the walls are now destroyed. So each one of these are supposed to expand and recoil. That's what happens when we inhale. We inhale, they expand, and then we exhale. They contract and then recoil, push CO2 out during exhalation. Can these still do that?
No.
No more. So they lose elasticity. Now, how did this happen? The same exact manner as what we discussed in chronic bronchitis, because the smoker caused the number of white blood cells, mucus cells to increase in number. Therefore, protease amount is also increased. So when you stop smoking at night, when you go to sleep, what will protease do again? Destroy lung tissue. So if this is the destruction here of the large airways, upper airways, there's also destruction here in the lower airways. Okay, still leading to the same COPD condition. There's a small population wherein I mentioned earlier the let's call it this one, alpha antitrypsin. Now, what is alpha antitrypsin? This is another enzyme used to break down or destroy protease. So if we have protease, we should have something that will inhibit or destroy protease, right? Because otherwise protease will keep destroying our lung tissue. So with an equal amount of protease, there should be an equal amount of alpha-1 antitrypsin. If the balance is good, then there will be no lung tissue destruction. Everything will equal out. It will balance out. However, in people, not necessarily people with COPD, some people have this is the genetic deficiency I mentioned earlier. So some people with no smoking history, but they have alpha-1 antitrypsin deficiency, they can still develop COPD, even in the absence of smoking in their life. Make sense? Okay, not through their own fault. Okay, they're just unfortunate. They don't have this enzyme, okay, that will counteract protease. There's supposed to be a balance. So you and I both have protease. I have protease, you have protease, but we also have alpha-1 antitrypsin, which will help destroy protease. That way, we keep the amount low so that it doesn't destroy our lung tissue. Any questions so far? All right, let's proceed. Just like heart failure, COPD has stages or grades. Now, you'll notice that what was our basis for acute kidney injury? for stage 1, stage 2, stage 3, stage 4?
Urine output.
Was it urine output or GFR? It was GFR, right? So here you'll notice, sorry?
For AKI.
No, AKI was the urine output.
Yeah.
Yeah, GFR was for CKD. Okay. You'll notice here in COPD, what do they use to determine the severity of the condition? Yeah, what was the basis? So you said urine output for AKI, GFR for CKD. What's used here? FEV1. Okay, so what is FEV1? So this is a measurement using pulmonary function test. Pulmonary function test is used to perform these measurements. Let me show you what it looks like. Now, the name is a spirometer, but this is not the incentive spirometer. Are we clear? This is not the incentive spirometer. Incentive spirometer is the small box. This one is a machine. It's a big machine found in a doctor's office. We only see these in clinics because we don't do this for inpatients. We do pulmonary function tests usually at the clinic, an outpatient visit, because we don't do the test when the patient is sick. So when you come in, let's say you have pneumonia, you have COPD, you have asthma, we can't do this function because is it an accurate test if you come in sick? No. So it has to be done when you are breathing fine, when you're healthy, okay, when you're feeling healthy. So they take you into the clinic. So it'll look like this. So they'll ask you to breathe several times. Here, you'll pinch your nose and have you do a few breathing maneuvers. Usually involves blowing into the device. So this is opposite the incentive spirometer. How do we use the incentive spirometer again? That's perfect example of not to do what not to do. Okay, so incentive spirometer. Okay, let me clarify. So this is the incentive spirometer. There's really no set time.
So it's not 6 seconds. I think we have to blow as hard as we can.
No.
That's for spirometer.
Okay, so the incentive spirometer, this one that you use at the bedside, that you give to your bedbound patients, this one they inhale into. Are we clear? So you put the mouthpiece here, the mouthpiece into your mouth, and then so this is incentive spirometer, right? So you inhale into this thing. So you put this into your mouth and then you inhale slow. And then it will of course rise, right? This ball here will rise. Okay, the deeper you inhale, it will rise all the way up to 4,000, 2,500, whatever you can we can do. Now we do this how often? Yes.
Every hour.
How many times?
3 times.
Every hour.
Is every hour?
How many times every hour? This is fundamentals. 10 times every hour. All right. 10 times every hour is every how many minutes? 60 divided by 10. 6 also. Once every 6 minutes. Okay. So how many times do they use it? Every waking hour. All right. Of course, you don't wake them up at night. Hey, it's time to do this. No.
So what did you do at night?
Say again.
What did you do at night? Just, you have to sleep.
Do you want me to wake you up at night? And have you used this every 6 minutes? I'd be glad to do that. No, the patient's sleeping. Leave them alone, okay? So this is done every waking hour, okay? 6 times, no, sorry, once every 6 minutes, so that's 10 times every hour, every waking hour. Are we clear? How is it used again? Inhale, fast or slow?
Slow.
Very slow inhalation. So that's the incentives parameter. This test here is different. Instead of inhaling, you will be asked to blow into this repeatedly. You'll receive instructions, so they'll set up the machine, then they'll ask you to blow into it as hard as you can when instructed. Okay, so it will measure. One of the measurements is the FEV1. So what does this stand for? This stands for forced expiratory volume in 1 second. That's why it's called FEV1. So if it's less than 70%, then that's grade 1. Less than 50%, less than, sorry, all the way to less than 30, then that's grade 4. Okay, that's pretty bad already. If your lungs are only able to do less than 30% of the total air that is supposed to be blown out, then that's pretty bad. Okay, so FEV1 over 80%, that's grade 1, 50 to 79, grade 2, grade 3, 30 to 49, less than 30, grade 4. Now, what do we remember from heart failure classification? Which ones were the pretty bad ones? 3 and 4. Same thing here. 3 and 4, that's pretty bad. You think you can still carry out any activity if the lung capacity, the lung strength is only less than 30%?
No.
Can't even make it to the bathroom. Okay, so that's how they diagnose your condition. Any question on pathophysiology? Let's go to risk factors. As I already mentioned repeatedly, what's the number 1 risk factor? Smoking. Okay, doesn't matter what you smoke. Pot, cigarette, tobacco, vape. No, sorry, I shouldn't say vape because we don't have evidence yet. But cigarettes, definitely, tobacco, or anything else like pipes, cigars, marijuana. They're all been proven to cause COPD. Okay. So not just smoking, besides smoking, it'll be age, occupational exposure. Say, let's say you work in an asbestos factory or drywall factory, for instance, wherein you're exposed to so much pollutants, tiny particulate matter. And as mentioned earlier, the unfortunate people who have alpha-1 antitrypsin deficiency. What is alpha-1 antitrypsin again?
Breaks down.
Protease, very good. Okay, so this is it counteracts the destruction of lung tissue by the enzyme protease. Now, as far as signs and symptoms, this will be the same as in heart failure. Was heart failure acute or chronic?
Chronic.
Mark? Acute or chronic?
Chronic.
No, what was your answer earlier?
He said both.
Both. Okay, both. That's the correct answer. It's chronic, but it can have acute exacerbations. Exactly the same as COPD. So there will be day-to-day manifestations. So for instance, in heart failure, did the patient with heart failure have symptoms every day?
No.
No symptoms? Meaning they're perfectly normal?
No, yes.
Yes, they have symptoms. So how do we know that they need to come to the hospital? Okay, so same idea here. So will these patients have day-to-day symptoms? Yes. So these are their day-to-day manifestations. There's chronic cough, sputum production, and dyspnea. They worsen over time. However, there will be some chronic changes. For instance, what do you remember from fundamentals? Because you talked about COPD. This barrel chest here, what caused this? Why did the patients with COPD have a barrel chest shape? Why did their chest wall look round instead of oblong like you and me? Okay, so here in this drawing here, if you have most of your lung tissue of your alveoli looking like this, so are they hyperinflated? Are they flabby? Are they able to empty completely?
No.
Okay, so if you have so much residual air volume because of emphysema, so what will happen to the diameter of your chest wall? Okay, so that's what causes the barrel chest. Can that be cured? No, you need a lung transplant in order to cure that, just like in heart failure. So same idea. So barrel chest is permanent. What else is permanent here? Yeah, of course. Yeah, we're talking about COPD. I'm talking about manifestations. What are permanent besides barrel chest? Let's talk about the okay, very good. If you well, I wouldn't say never. I wouldn't say that. Okay, yeah, because we can't achieve 100% on COPD patients, okay, with oxygen therapy. So here's the chest wall. So this is the same person, but this one non-COPD, look at the chest wall now, chest diameter after COPD. Okay, this is what we call the barrel chest. And this is what it looks like. It's supposed to look like this, oblong. But because of the lung tissue, the alveoli becoming flabby, now it becomes almost a perfect circle. What about what happens to the fingers with chronic hypoxemia? The fingernails? What do we call that, Caroline? Clubbing. Okay, the finger clubbing. What causes the finger clubbing? This one, the clubbing of the fingers.
Hypoxia?
Okay, chronic hypoxia. Okay, not acute hypoxia. Acute hypoxia won't cause this. This is chronic hypoxia. So over several months, over several years of your oxygen levels being below normal, it will cause your fingernails, your fingertips to club. Okay, so they will curve as a result of compensation. Okay, a result of chronic damage to those tissues. So they will curve. So the barrel chest, the clubbing of the fingers, are they?
Isn't that an indication of lung disease?
This is lung disease that we're talking about, COPD.
Finger, like a sign and symptoms of it.
Which is what COPD is. Correct. So is this therefore related to what you're saying? Felicia. Is the finger clubbing exclusively seen in COPD? Can it be seen in asthma patients?
Oh, yeah.
Can it be seen in heart failure patients? Can it be seen in sickle cell disease patients? Yes. Okay. Because any patient who has chronic hypoxemia will develop finger clubbing. Understand? Okay. And this is the typical posture. They usually sleep in a chair because they can no longer enjoy the bed because now they'll require so many pillows in order to sleep, which can be uncomfortable. They are most comfortable in a recliner. So same as CHF patients. So heart failure patients, COPD patients are about the same. So they can't sleep. What do we call that condition again? Can't sleep laying flat. What do we call that condition when you cannot? Orthopnea. Okay. Okay, so the P there is not pnea. Okay, so it's just orthopnea, dyspnea, bradypnea, right? So orthopnea is the difficulty sleeping, laying supine or flat. So as already mentioned, so the patient's FEV1 will be low depending on the grade. If it's gold 1, 2, 3, or 4. So as the patient progresses, then the lower the FEV1 will be. What is FEV1 again? Expiratory volume in 1 second. Okay. Right here. FEV1 is forced expiratory volume in 1 second. How much can you blow in 1 second into the spirometer? So it will measure how much you are able to blow. Okay, how much percentage of the air in your lungs is forced out in 1 second. So that is the FEV1. Are we clear? Right. Meaning the normal is 80% of that air is supposed to come out. Okay, so that's normal FEV1. If you're able to blow out 80% of, because your lung completely empty when you exhale? No, impossible. Okay, because otherwise, if it completely empties, then what's left in the alveoli? Nothing. So what will happen to your lungs? It'll collapse, right? So therefore, 80% is normal, over 80%. And then, do you understand? As the percentage drops, what happens to the residual air in your lungs? Okay, so again, so if you're supposed to blow out over 80% of the air in your lung when you exhale, when you blow like that, 80% is supposed to come out, only 20% left. So if you're only blowing 50 to 79%, okay, so is that old or new air? That's old air that's left behind there. So imagine if it's only less than 30% that's coming out, how much old air is in your lungs? Over 70%. Is that good or bad? What is that air mostly? Is that oxygen or CO2? CO2. So you understand now why people with COPD have high CO2 levels. Okay, so this is the reason. Okay, so they're simply unable to get rid of the CO2. Okay, they cannot empty their lungs completely. So therefore, if let's say in grade 4, if they can only expire 30% or less of the air, how much is retained? 70%. So if you have 70% residual volume after each breath, how much new air can you get in?
30%.
Less than 30%. So you understand why it becomes a vicious cycle, correct? So every single day, are you able to get in oxygen? No. Very difficult to get in oxygen. So if it's difficult to get air out, it's even more difficult getting air in. Any question on the nature of COPD? Again, there are how many types of COPD? What are they? And chronic bronchitis. Both will result in this condition. So whether it's the upper airway that's involved, here's the upper airway, okay, chronic bronchitis, and then you have the lower airway, right? So it will result in the same thing, okay? Because here, if your airways are narrowed, can you get or can you get rid of air or get in new air? Same exact problem, right? So how much more if you have both problems? You have this chronic bronchitis and you have emphysema at the same time. Hey, imagine how your life's going to be, right? Okay.
So is that that's when you said that when you have both, that's when you have in the second stage?
I didn't say that. It it depends on how much, again, what's the basis for the grading of the COPD? Which is called what? Here, the classification, what did we use? FEV1. So to answer your question, Parpati, what will be the basis for the grading? The FEV1. How much is your FEV1? I can't answer what you said. If they have both, they have what grade? It depends. Okay, depends on how much is their FEV1. Okay, how much can the patient expire in 1 second?
Based on the everyone you can.
FEV1. Mhm.
What is FBC?
Forced vital capacity. But it's not as accurate of a measurement compared to FEV1. FEV1 remains the standard for grading the severity of COPD. Because forced vital capacity can also be affected by your chest muscles. Let's say if I work out, granting, or let's say I'm younger, I may have a good FVC, but then bad FEV1. That makes sense? Because FEV1 is really just based on your diaphragm. Because think about it. Is it really the lung that's forcing the air out? I mean, lung is a smooth muscle, right? So what's really when we do that? What muscle is really doing that? It's the diaphragm. Okay, it's not the lungs, is it? Can lungs do that? No, lungs are muscles, but they are smooth muscles. Okay, the diaphragm is really the breathing muscle. Understand? Okay. So as again, signs and symptoms. I won't read the entire paragraph for you, but you have to be able to distinguish between what are expected, meaning day-to-day manifestations of people with COPD. For instance, here. So when in this particular paragraph here, are these talking about day-to-day or signs and symptoms of an exacerbation or an acute attack? What does the paragraph start with?
Signs and symptoms.
With that what?
That need the supplies of oxygen.
So therefore, is this day-to-day?
Yes.
Read the entire.
No.
You
said day to day and then other thing.
What was the other question?
Question you said?
Cause you said I heard day to day.
Okay, so just like heart failure, are these patients ever going to be normal? No. Doesn't mean do we admit them every time because they have barrel chest, they have finger clubbing, they have a respiratory rate of 22 instead of 12 to 20. Do we send them to the hospital? No. So therefore, are those day-to-day manifestations?
No.
The barrel chest, the clubbing of the fingers, the respiratory rate of 22. Are they day-to-day manifestations? Yes.
Sorry, my brain is fried.
Okay. So you need to recognize again so we're not doing much here because you're already pretty much telling me you don't want to be here.
Felicia.
This will still be on next week's quiz. So you need to recognize what are day-to-day manifestations and what are the signs of an exacerbation, meaning does the patient need to know when to come into the hospital or when to call their doctor? Okay. Is it the same as in heart failure?
Yeah.
Exactly the same. So patients with heart failure know their daily manifestations and they should be taught also what to report. Let's say, let's review heart failure. When do you tell a patient with heart failure to go call their doctor or call 911? Acute or chronic? Acute shortness of breath. Okay, so that's an example. What if they gain 3 pounds overnight?
Yeah.
Because that's another acute thing, right?
Yeah.
Very good. So therefore, it's the same pattern here. So if you see chronic manifestations like the barrel chest, the finger clubbing, are those acute? Obviously not. Those are no reasons to see a practitioner, okay? Because that's going to be there forever. However, acute symptoms, let's say they're now they used to be able to, let's say, walk to and from the mailbox or walk to and from the bathroom. Now it's a chore now just to reach the bathroom. Is that an exacerbation?
Yes.
Definitely. Okay. Does that help? Okay. So again, acute, you report. Chronic, you manage by yourself. Is it too late to stop smoking?
No.
They already have COPD.
I mean, it will make the.
Why do I need to quit? It's too late now.
Slow down. the-
Very good. So smoking cessation, most of them will say, thank you very much, but I still like to smoke. Okay. Doesn't mean you give up. Okay. So you keep every admission, you talk to them. There will be a certain moment that they will say, yes, I'm ready to quit smoking. Okay. So you still have, and again, nurses are at the best position here to encourage them to stop smoking. Let's go to oxygen therapy. What did you learn previously about oxygen and COPD patients? How much oxygen can we give? Okay, very good. Remember that room air is 21%. So we start with 2 liters, that's about 24%, and then every liter goes about to 26, 28%, etc. However, can someone read this for me? Rihanna.
Oxygen transport to tissues depends on factors such as cardiac output, arterial oxygen content, concentration of hemoglobin, and metabolic requirements. These factors must be kept in mind when oxygen therapy is considered for use in all patients regardless of underlying.
Okay, particularly the last few phrases. The last 2 phrases said is considered for all patients regardless of underlying disorders. Does this include COPD patients? Yes. So the principle here is if the patient needs oxygen, do you give it? Yes. If the patient needs more than 2 liters, do you give more than 2 liters?
You can give up to 6. You can give up.
Yes. Yes. Don't forget, disregard the order. You have an order for oxygen. This patient has COPD. Do you give oxygen if they need it?
Yes.
I just want to make sure you understand that. Okay. So don't deprive people with COPD oxygen if they need it. Are we clear?
Yes.
Okay. Because that's what does this sentence mean? What does this say? Oxygen is considered for all patients regardless of the underlying disorder. Now, this doesn't mean that you put them on a non-rebreather forever. Do you understand? If they need it, okay? If they need the oxygen at this moment, they need it, give it.
So
Okay.
what you're saying is that if a patient comes in and severely
Yeah, and they have COPD.
depressed, right?
Mhm,
And then we can only administer 2 liters of oxygen. And we see that the person is severely
mhm,
stressed.
correct.
Do we administer higher than it?
It's a doctor.
I know we need an
Yeah,
order,
you
like
need
you
an
said.
order. Yeah.
But if the person is severely distressed,
Uh,
can you do it?
yes,
Yeah, and then get the other life.
but you need an order.
Oh, okay.
All right.
Okay.
Now, don't take it literally, okay? Use common sense. What are you gonna do? This patient's here in distress. Let's say it's Yannick. Yannick's doing it. Yeah, are you just gonna stare there and say, I'm sorry, I can't give it to you because you have COPD? And then she had, I'm sorry. Go get the freaking order and then give her the oxygen. Are we clear? All right. Complications. As with any other chronic condition, there are complications. This can result in heart failure. What type of heart failure is likely to happen? Left or right side?
Left.
Which side of the heart pumps blood to the lungs?
The left.
Which part of the heart pumps blood to the lungs?
Right.
The right side. The left side receives blood from the lungs. Correct? So what type of heart failure will result? Right side. Why? It will be extremely hard because imagine those structures, the pulmonary, the chronic bronchitis and the emphysema changes. Remember, those are containing blood vessels. So what will happen to those blood vessels? Will there be hypotension or hypertension in those blood vessels in the pulmonary circulation? Hypertension. So therefore, if there's, what happens to the afterload therefore? High or low? High afterload because the vessels are very narrow. So therefore, is it easy or hard for the right side to pump blood to the pulmonary circulation? Extremely hard. Be careful, as with any other therapy. Is oxygen a medication?
Yes.
Yes. Can you possibly give too much? These are your signs and symptoms of oxygen toxicity. Okay, so when giving oxygen to a COPD patient, use the lowest amount needed to maintain an acceptable PaO2. Is PaO2 the same as SaO2? What is PaO2? Partial pressure of oxygen. So therefore, is this in the artery or in the capillary? Capillary is SaO2. Okay, so this is, what's the value of PaO2? What's the range? 80 to 100. 80 to 100. Are we clear? So how much oxygen? So let's say the example I gave earlier, you had to use a non-rebreather to achieve 92% on a COPD patient. Do we leave them at the non-rebreather? No, because that is not following the lowest amount. So they may have needed the non-rebreather at that moment. Doesn't mean they're going to need it forever. Are we clear?
Yes.
Okay. So if the patient's symptoms are better, then you titrate down. Okay, remember, what will happen if you give them too much oxygen? Toxicity. Okay. Look, it will cause lungs to collapse. Okay. Refractory hypoxemia. It will not help anymore. It will kill the patient. Let me explain one more concept. So when we say FiO2, what does that mean? Fraction of inspired oxygen. What does this mean? FiO2 stands for what? How come its percentage? 21%, 24, 100%. What is this really talking about? The oxygen concentration that you are breathing. Right now, what are we breathing?
Is that 21%?
21%. All of us are 21%. So if I put you on oxygen, are you still breathing 21%? No, I'm giving you higher FiO2. You understand what is FiO2? Okay. Now go back here. If I give, if I'm breathing 21%, that means when I inhale, 21% of that is oxygen. What is the remaining 79%? What are those made of? Mostly nitrogen. What else? CO2. Okay, so room air right now, the air in here in this room is about 70% nitrogen. It's about 21% oxygen. So that means it's about 7% CO2, and the other is somebody's fart and other gases. Okay, so that's what the concentration of air is. So let's say you give 100% to somebody. That means how much oxygen is in the lung if I'm giving you 100% FiO2? So how much oxygen is in my alveoli? If I give you 100% FiO2, it's 100% oxygen, pure oxygen. So that when that oxygen diffuses into my bloodstream, what's left in the alveoli? None. So what will happen to the alveoli? That's what we call absorptive atelectasis. So is it good to give someone high FiO2 for a long period of time? No. When we give high FiO2 like that, which is very seldom, it has to be on either on a ventilator or on a BiPAP machine or a CPAP machine. Are we clear? Because with no machine, no positive pressure ventilation, it will cause collapse. You understand that?
Yes.
Okay. And you know this, right? I mean, I hope this is common sense. Whenever you have oxygen, there should be nobody lighting a match or a cigarette. Okay. Okay, I have 1 or 2 questions on this table. This is the oxygen concentration, depending on the delivery device that you're using. So which one is testable? It's really on the flow rate. So on the nasal cannula, how much is the maximum you can give? 6. That's 6 here.
You start with 2.
On a nasal, 1 to 6, the same. You have a simple mask. So if you're giving 7, what should you use? It says 8 to 11. So how much should you use if your order is less than 8? A cannula. Okay. Non-rebreather, minimum is 10. So what is this saying? What does this mean here? Can we use one oxygen delivery device for all flow rates? No. So you use the appropriate device for the ordered flow rate. Are we clear? So can I use a mask to deliver 2 liters per minute?
No.
Can I use a cannula to deliver 10 liters per minute?
No.
All right, very good. So are we going to embarrass ourselves and then put the wrong oxygen delivery device? Okay, I hope not. Okay. All right. I still have 2 minutes. So that's about oxygen delivery. Let's go to medications. Okay, and then we'll stop here. COPD, is this acute or chronic? Do they have acute exacerbations? Yes, just like heart failure. So do I have the same medications used for the chronic state as well as the acute state? No. Okay. And vice versa. Okay. So mainstay are bronchodilators. We have several bronchodilators. You're familiar with LABA and SABA? LABA are your long-acting bronchodilator agents, and SABA are your short-acting bronchodilator agents. Okay. The medications are not here, as I mentioned, because where are they listed? Under asthma. Okay. Okay, let's just stick with this table for now, and then I'll continue next week. So what's the difference between MDIs and DPIs? MDIs are wet medications. Okay, these are the sprays. Okay. We do have modern, this is new in the last 5 years. We have PMDIs now. These are different from MDIs. MDIs are the ones you actually have to press on a canister and it will spray the medication. So it will spray wet medications into your airway. Now, a pressurized meter dose inhaler is actuated by your breath. So these things have a tiny battery. So instead of your finger pressing on the canister to dispense the medication, this one is activated by the patient's breath. So when the machine senses that you are sucking into the mouthpiece, it will spray the medication. Does that make sense? Okay. So which one is better, a PMDI or an MDI? Because if I have a old patient, can they time it correctly as to when they press the canister and then when they suck into the medication in?
No.
They cannot time it. This one, however, a PMDI, since it's activated or actuated by the breath, when I inhale, it will spray the medication. So which one is better? The PMDI, right? Because costs of repeated hospitalizations, the number one cause is incorrect use of the patient's inhaler. If patients aren't using it correctly, so therefore, are they bound to have acute episodes? Yes, because they're basically not getting their medications, right? All right, I'm out of time. See you next week.
So Chris,